Kathleen, and thank you very much to Anand Grover for coming over to Ireland at a really crucial time for women's human rights, and particularly women's human rights to health. My presentation today is going to focus on the consultations that were held with women across Ireland to give voice to exactly what you were arguing, to give voice to women's concerns and their right to health. It was undertaken under the auspices of the Women's Human Rights Alliance as part of the shadow reporting process, as was mentioned, into the United Nations under the International Covenant on Economic, Social and Cultural Rights. 13 workshops were held across the length and breadth of Ireland with women in rural areas, women in disadvantaged communities, women living in poverty, traveller women, Roma women, refugees, asylum-seeking women, women with disabilities, lesbians and older women, the diversity, the full diversity of the women that we are. Many detailed and broad-ranging recommendations were made during the consultations that were fed into the report. An overwhelming number of women stated that they did not have a right to health, and I think that is a really damning, conclusion to have of our state today, that the women do not have the women who were consulted said that they did not have a right to health. So I just want to say a few things about the issues that came out of these discussions, about women's concerns about their health and well-being, about their reproductive and sexual health, about access to health services, about support in providing and receiving health care, about the critical issues facing carers today, and many more issues. There are issues that concern minority ethnic women, family carers, there are issues around gender-based violence, the need for women to have choice to access a safe abortion, and an issue really that runs and underpins all of this is the need for us to have a much broader gender-sensitive and gender-sensitive approach to looking at gender inequalities in health and within the broader context of the social determinants of health that were mentioned earlier. Underlying all of this, what I want to say really is that the women's right to health, when we discuss this issue, needs to be framed on the basis of a number of guiding principles. These guiding principles came out of the consultations with the women across Ireland. First of all, that we should judge and assess any policy, not just in health but across the board, any policy for its impact on key areas of women's lives. In other words, to have gender impact assessment on how this impacts on the multiple and complex inequalities experienced by women. Second, we should ensure that the same impact assessment takes place to analyse the extent to which policy measures coming from the government take into account care relations and an ethic of care. This means valuing care as a core societal and public good, and valuing also the many good workers who provide excellent care in the care system. This should bring an ethics of care based on equality, dignity, trust, respect into the centre of our policy discourse and in our service delivery. Third is that a fundamental issue is that any change in government policy should be assessed for the impact on women's health and women's health status. And fourth, that all policy impacts, all policy actions impacting on the right to health must give voice to women's concerns and priorities, and the full participation of women, particularly women living in disadvantaged communities, and in relation to the health and the right to health and the development of women-focused health services. This should be based on a rights-based approach which should underpin all approaches to policy development, service delivery and service planning. Now, if we were to take those four founding fundamental principles as a guiding principle for our healthcare system, we wouldn't get into the trouble that we get into at the moment in many cases, where women are denied the right to health. And I suppose I can say with a resounding, there has been a resounding failure on the part of the state to strategically integrate these guiding principles into our healthcare system and beyond. They are, and they should be the basis upon how we should be evaluating and measuring all policy interventions and outcomes for the realisation of women's right to health. They should be the basis for this. excuse me, underlying this is the importance of participation, of empowerment, of social justice as a basis for raising awareness and ownership of human rights, in terms of women's ownership of human rights. And it was interesting when the consultations took place across the country, it was around all of the various elements of Article 12 of the Covenant, and particularly the General Comment 14. So they became the basis for the consultations. The consultations in and of themselves were participatory in nature, and they were designed to help women take ownership of human rights and norms and women's human rights for themselves. I want to just say a few words about the social determinants of health, because this is important under the Covenant, that we have a real, I suppose, problem in Ireland that has been repeatedly raised in many, many pieces of research and policy documents and through the consultations, that unless we focus on the social determinants of women's health by locating the right to health within the broader context of economic and social policy, we're not going to get very far. Changing our healthcare system itself requires us to look beyond the healthcare system and into the whole area of social, economic, cultural, political factors impacting on women's health. So this is in relation to gender equalities in the family, in the workplace, in relation to poverty, housing, employment, training, work, participation in public life and politics, participation in the community, and so on. So this broad context is absolutely required. And what we know, and we know from the evidence, and we have been sitting on this evidence for decades now, that women experience higher levels of poverty than men. However, the social determinants of health are absolutely critical in this broader discussion about the right to health. It's relevant to understanding the right to health in relation to the rights of traveller women and Roma women, who in a moment will speak about their testimonies, about the impact on their health and well-being of discrimination, poor living conditions, including the absence of things like clean water, sanitation, and levels of mortality and morbidity that compare with those in some of the poorest developing countries across the world. They're also relevant to the appalling living conditions and enforced isolation from work and society of asylum-seeking women in Ireland, and also in relation to women living in poverty and isolation, who do not only experience poor access to healthcare, but experience poverty and inequality that leaves them vulnerable to ill health. One of the most important issues coming out of the consultations was the need for a gender-based approach, and that this should take account of, as I mentioned earlier, the multiple inequalities faced by women. The government, the Department of Health, the HSE, must adopt a gender-based approach in order to take account of these broader biological and social cultural factors that influence health. A gender-based approach to healthcare should take account of the services that are most important for women, for example, in relation to sexual and reproductive health, childcare, maternity services, services that address abuse and domestic violence. And many women in Ireland have said that they feel that many of these areas are the areas where their rights are undermined or compromised or violated. They argue that healthcare policies should be underpinned by the principles of human rights, equality, inclusion, and participation. With regard to sexual and reproductive health, it's clear that the failure to legislate on the X case puts women's lives at risk. The criminalisation of abortion in Ireland compromises women's rights to make choices about their health and to receive healthcare that not only does not put their lives at risk, but also gives them human rights, bodily integrity, dignity, choice, autonomy, and safety in their lives. So we don't want to have a situation where our services are unable to respond to these issues of dignity, bodily integrity, safety, security. So that means that the planning and the provision of services need to take into account the integrity and dignity of women's lives and the specific experiences of groups of vulnerable women, women including migrant and minority ethnic women, lone parents, lesbians, disabled women and older women, for example. Services need to be planned and delivered and monitored for their impact on women's health and health inequalities and in relation to access to services that is equal. Sarah Burke in a moment is going to say a few words about the impact of the cuts on the functioning of the healthcare system, and I don't really want to dwell on that issue, But I suppose it is important to say that in the context of the consultations that took place, and since the consultations have taken place, we've seen a much higher incidence of ill health, of widening health inequalities. But we've also seen the impact of government cuts on the functioning of the healthcare system and the impact on frontline services, and particularly support to family carers and other groups who experience high levels of stress and difficulty in providing care. But also we've seen the attack on our equality infrastructure, and I suppose I just wanted to mention that the Equal Status Acts don't effectively cover anti-discrimination in the public healthcare system. Often people think that the Equal Status Acts cover every aspect of the public service, but they don't. There should be a positive legal duty on the health services to promote equality between women and men, and the removal of this exemption in the legislation in relation to healthcare services. Cuts in public services and health have had a disproportionate impact on women, and particularly in terms of women's access to healthcare services, their roles as carers, but also in relation to, and I think it's really crucial to mention this, in relation to cuts that have taken place within the community. Many community-based initiatives which provide essential support, information, empowerment for women locally in relation to healthcare. Without that glue within the community, without that community cohesion, some of the issues that we're concerned about are going to be exacerbated in the future in terms of the health and well-being of poor, vulnerable and marginalised women. These services and initiatives have been severely cut. I want to say a few words about availability, accessibility, acceptability and quality of healthcare services as well, and the issues that came out of the consultation. A huge number of comments were made about women's right to health in relation to accessibility and availability. And I want to just highlight a few of these. There's far too little time to be able to cover all of these. But most importantly and resoundingly, they were about the two-tier healthcare system, about it being unfair, inequitable, and leading to poor quality healthcare services, compromising accessibility, acceptability, and quality of care for women in Ireland. So the longer waiting times for public healthcare patients, the poorer quality healthcare system, particularly affects women because the disproportionate number of women who are old, lone parents, poor, vulnerable and marginalised are reliant on this inequitable public, or the inequitable two-tier system, but they're reliant on the poorer quality services that arise from the public healthcare system. As was mentioned earlier, if you have the money to buy healthcare and to buy voluntary healthcare insurance, you can effectively queue jump. And what we have is a healthcare system with extraordinary long waiting lists for public patients, although they're coming down in the hospitals, but extraordinary long waiting lists within the community that are not subject to some of the controls that have been put in place by the government recently under the special delivery unit. So user fees, which are common, are a major deterrent to the take-up of community-based services. If you're just above the threshold of a medical card in Ireland, you have to pay between 60 and 80 euros to go to the GP. You have to pay 100 euros to go to A&E. Many of the women at the consultation said that actually their right to health was compromised because they couldn't go to the GP. There was one woman, I mean, just to pick out, a few examples. One woman said, who had a long-term illness, that she'd stopped going to the GP or continuing to take her medicine because the costs were so high. Another woman talked about the high cost of medication, and she had stopped taking her medication, and she said, my right to health has been denied me because I can no longer afford to take my medication. These are many of the examples that came out of the consultations. A woman with disabilities was unable to avail of specialist disability aids and appliances because she was on a medical card and they weren't available for medical card holders. Things like not being able to have the right glasses or footwear because you're a medical card patient means that your right to health is compromised, your mobility is compromised, and your ability to participate in society is denied you. Many of these cases have been reported by the Ombudsman, Emily O'Reilly, in recent years, that the Department of Health and the HSE are responsible for large numbers of cases of neglect and inequality in the healthcare system, of poor quality services and deficits in accountability, where arbitrary and discriminatory decision making has eroded rights, for example, to enable women to continue to carry out their roles as carers in the home, and often ending up with a system in place that costs far more because older people are unable to stay in their own homes. Other criticisms were made about the lack of implementation over time of some of the core strategies that we have today in Ireland. Vision for Change, mental health strategy, it's an excellent strategy. You know, it's been around since 2006, has barely been implemented. The primary care strategy, 2001, is only just beginning to be implemented. The resource commitment for those key areas has just not been put in place. And that's not to say that the healthcare staff in the healthcare system are not carrying out an excellent role in their work. Because in fact, many of the people that we spoke to in the consultations said if it wasn't for the kindness and the kind of, I suppose, the extra additional help that was given me by the public health nurse or the nurse in the hospital, or by the speech and language therapist who worked extra hours to give me the service because I had to wait 2 years for this particular service. All of those issues came out in the consultations about, you know, how good many of the staff are, but the stress that they face. And we have to remember that many of the staff working in the healthcare system as carers are on the lowest pay. Often carers in home helps and others are on the minimum wage. They're not earning large amounts of money. We don't value our carers in the way that we should. So you could argue in relation to women's human rights, the issues about low pay within the care system are absolutely crucial. There were lots of specific human rights infringements that I'm not going to go into the detail of, but I do want to say that some of these examples are about the low prioritisation of women's health needs, medicalisation of healthcare, and particularly, for example, overprescription of medication was highlighted by poor women, by traveller women, women in the asylum-seeking process. Appropriate solutions were not available, for example, for counselling for the poorest and least powerful groups of women. Attitudinal barriers and lack of knowledge by health professionals of women's health often resulted in embedded assumptions about women's symptoms being related to menopause, addiction or depression rather than to something like a cardiovascular disease, or in relation to understanding women's mental health needs. In many parts of the country, an absence of community-based services and well women clinics, lack of accessible information about services, biomedical determinism and a male approach to health leading to negative attitudes. I could go on, and in fact, I'm probably getting way over my time already, Kathleen, so lots to say about all of these things. You can read them in the report. But I just wanted to, I suppose, just say a couple of words really to finish off about women from a diversity of backgrounds raised issues time and time again about gender-based violence and the issues of gender-based violence on women's health. And I want to say this because it's really crucial, because the gender-based violence responses are, multiple stakeholders, but they are also relevant in the healthcare system, and the HSE has made great strides to develop policies and protocols around gender-based violence, but it's a grossly under-resourced area. What we found from the consultations was that women believed the state had failed to provide an effective, coordinated and well-resourced response to gender-based violence, and that this constituted a violation of women's human rights. The lack of a systematic approach to the prevention of domestic violence and limited resources around women's safety were key issues. Finally then, just to sum up, a human rights approach to health has the objective of increasing accountability. Accountability of governments for health. It also means that governments should not impose retrogressive measures and provide minimum standards that are essential to the enjoyment of health. So I think we should hold that in our minds at this crucial time. The right to health must be embodied into Irish law, many countries across Europe and across the world. have a constitutional legal right to health. We don't. This is an ideal opportunity at this time of a constitutional convention taking place to embody the right to health into our constitution and to embody women's right to health as part of that. A gender-based approach and gender impact assessment should be integral to all health policy decision-making and planning, and crucially, outcomes should be acted upon. Providing quality care and saving women's lives should be central to human rights considerations. These should be based on dignity, respect, trust in a healthcare system that is universal and accountable. I haven't said anything about the government's current plans about universal healthcare insurance and its restructuring of healthcare at the moment, but there are some fundamental problems that the government, with the government's plans for universal health insurance. They will lead to much greater commercialisation, privatisation, and I believe greater inequalities in health. We have a two-tier healthcare system at the moment. This could lead to a three-tier healthcare system, let me warn you. Providing quality care and universal healthcare should be on the basis of redistributing resources so that disabled women, for example, can live independently in their communities and work. Older people can live independently, and so on. And finally, a core purpose of our healthcare system should be to redistribute resources, and I'm talking here about health resources, to the poorest and most disadvantaged women and in their local communities. And through this, address gender-based inequalities in health and guarantee quality healthcare for all women. Equitable and accessible healthcare services should contribute to social justice and the dignity and equality of everyone. These should be the starting points to inform and guide our healthcare policy in Ireland in the future, and to ensure that women can enjoy and claim their right to health. Thank you very much.